Kia ora koutou, welcome to our first webinar of 2025. It is a pleasure to welcome you all in our panel this evening to discuss trauma in rural New Zealand. My name is Lucinda Thatcher and I'm your host this evening. And our panel, who are in variable locations around New Zealand, and it's certainly been an evolving panel in which I think highlights the flexibility of rural clinicians and clinicians throughout New Zealand. So on our panel, and they'll introduce themselves shortly, we have Dr. James Moore, Dave Dixon, Joel Tzing, Justin Venable, and Jono Wills. And we welcome you all this evening and look forward to discussing trauma. Our sessions are supported by the Section of Rural Health, Department of General Practice, University of Otago, and the Division of the Rural Hospital Medicine within the Rural New Zealand College of General Practice. We are endorsed for 1 hour of EME by the General Practice College. We'd love this session to be interactive and we hope to provoke and stimulate you in how you manage trauma. We welcome comments and questions in the chat, and I would love to start 2025 by you all completing my evaluation form at the end of the evening. I can then lodge your CME points for you if you put your medical council number in. I do want to formally acknowledge our panel, who are not only a group of neat people, but also astute clinicians. Thank you very much for your expertise and time this evening. So I will now hand over, so if we start, say, at the top, as we go down. Do you want to start, Jono, and then we'll go Dave, Joel, Justin, and James?
Sure. Kia ora koutou, ko Jono Wills Takawangawa. I'm a rural hospital doctor based out of Dunstan Hospital in Clyde, Central Otago.
Hello, I'm Dave Dixon. I'm a background of an ED doctor working in Queenstown, and also teach the ED trauma paper with Jono as well, and a couple of the trauma courses, so the risk course and the emergency trauma management course as well.
Joel?
Just muted, Joel.
Kia ora, I'm Joel. I work up in Kaitaia. I think I'm here because we don't have a CT scanner, so just to discuss some of the challenges with that.
Way more than that. Great to have you. Thank you for filling in for us. Justin?
Kia ora tātou, Justin here. I'm a rural doc on the West Coast and also work as a flight doctor for HIMSS at the different bases across the South Island.
And James?
Kia ora koutou. I'm James Moore and I'm a trauma and intensive care medicine specialist at Wellington Hospital, and I'm the National Trauma Co-Lead for Health New Zealand. So pleasure to be here. Thanks for the invite.
Thank you for all coming. So I'm now going to hand over to Dave, who is going to lead us through the presentation.
Thanks very much.
And we're going to have a look about, initially, Dave, if we run through it, why are we going to talk tonight about rural trauma?
Okay, so I'm going to hand over to James in just a second, but I think, rural trauma is really common for us in New Zealand, and maybe we don't see as much of it due to the sort of trauma networks and pathway of care, but it comes to one of those sort of high acuity, low occurrence events that are really important for us to get right in the rural setting. So I'm going to segue on to James, who's just got some data about trauma in our rural places.
Cool, thanks, Dave. So the first point I make about these slides is I've pulled some data out of the New Zealand Trauma Registry. So we're very lucky in New Zealand in a way that we collect data on all major trauma patients that are admitted to hospitals in the country. So we're one of the few countries that has like a national data collection on trauma, which is actually really valuable. One of the areas of focus in our annual report, which is up until June of last year, is on rural trauma. And so I've just presented a few graphs on kind of to start us off and give us a little bit of a sense about the scope of the problems and kind of where rural trauma particularly occurs. one plea is that this hasn't actually been released yet. So if you can just refrain from screenshotting and tweeting it, that would be great, because it's currently with the Minister of Health's office for sign off before it gets released. So I don't want to get in trouble. Yeah, thanks, Justin. So the first graph here is looking year on year and rates by population of urban versus rural trauma. So the rate of trauma for people that live in rural areas is approximately 30% higher than people that live in urban areas. And that might not be much of a surprise to some of you, but that's been pretty consistent over the last few years. And so we expect to see, around about 60 cases of major trauma per 100,000 population. I'll go to the next slide. And where does that trauma come from? And particularly, where does that difference come from? Well, it's mostly driven by transport-related incidents, and many of us will remember the Rural People Die on Rural Roads, advertising campaign from Land Transport a number of years ago, and that is still the case at present. So there's a much higher rate of being injured in rural people due to transport-related accidents or crashes, I should say, and other mechanisms of trauma are not. Tend to be very similar. The other group is a very diverse group, and it's quite hard to dig down any further into what that exactly is. So overall, our rates of major trauma in the country are around 50 per 100,000 people, and that equates to around 2,600 New Zealanders affected by major trauma every year. And when I talk about major trauma, really I'm talking about people who have an injury severity score of 13 or more. And what that means is that to get an injury severity score of 13, you really have to have either a critical injury or multiple injuries across several different body areas. So if you were to just have like a fractured femur, you wouldn't make that cut off. You'd have to have like a fractured femur plus some busted ribs and a splenic laceration to get into that. So really, we're talking about quite significant trauma to get into those data. Cool. When we break it up and look at who's affected by trauma, this is a problem for everyone, but like many of our health statistics, Māori are disproportionately affected, and particularly tāne Māori. So Māori males have excel in major trauma, unfortunately, and have rates well in advance of other population groups. And in particular, interestingly, in this report, which you can look for next week if you're interested, a lot of that is driven by transport-related crashes, and young Māori males are particularly at risk in this particular area. Cool, thanks, Dave.
So I guess comparing this to our sort of tertiary counterparts, this is maybe a fairly typical trauma call that happens in a tertiary centre. And in comparison, maybe on a good day during daytime in our rural hospitals, this might be the approach that would happen if you have a significant trauma patient, if there even are trauma calls in the hospitals that you work, because often it tends to be there's a trauma patient comes in and it's the same staff that are working that were working, and in any case there's nobody else extra to call on. But I do think it is really important to recognise what happens in our tertiary places, because we want to try and bridge the gap for our rural patients to give them the best care possible in our rural areas. Jono, do you want to?
Yeah, I think following on from that, it's we've identified that rural trauma is happening at a higher rate. It's happening in our neck of the woods, so it may well turn up on our doorstep, and we'll go on and talk about some of the reasons why it may come to us in a minute. But there are some other factors rurally that come into it as well. We've obviously talked about staffing, but transport is another big issue for us. You know, when a patient comes to us, we are unlikely the place of definitive care, so we have to think about onward management. And certainly when you're a couple of, well, 3 or more islands down the bottom of the Pacific Ocean, weather can play a big part in that and make it difficult to move patients on. We'll come back to a bit more the differing access we've got to radiology around the country and how that might change our decision making. Talked about the fact that our rural hospitals will often not deliver the definitive care, and what blood products we may have to support major hemorrhage is also going to be pretty variable across the country. So there's a number of factors that we need to think about differently than what happens when a patient gets drawn in the door of a major emergency department in a big hospital.
All right, so we're going to move on and talk a few sort of case-based scenarios that's probably going to elicit some of those challenges that we have in rural hospitals. So this was a patient from a few years ago who came in on my night shift in the middle of the night in Queenstown. It was a young 28-year-old found on the side of the road with very sort of unclear story as to whether he'd been hit by a car, was just found on the road, whether they were intoxicated, and there wasn't really much information from the ambulance crew themselves secondary to this. And these were the observations that were called through to us in the hospital. So the patient's tachycardic at 120 and hypotensive at 80/50, but with normal sats, slightly increased respirate rate, and the patient's cold at this point. Justin, from a sort of ambulance or pre-hospital perspective, can you talk us through sort of the communication and how we get the best out of our communication with our sort of pre-hospital colleagues, including yourself?
Thanks, Dave. So just briefly, ideally we would have had an R40 handover radio call from the pre-hospital team that may prompt us as rural clinicians to, if we have access to a trauma call, so who can we ask for additional pairs of hands? Do we have any blood products? Do we need to get our blood bank in? How can we prepare for this? When the pre-hospital team arrives, it's such a, I mean, even in rural hospitals are quite a heterogeneous resource in terms of our spectrum of what we can offer. And the same is true for pre-hospital teams. It could be a highly skilled group of professional resuscitationists that could comprise of critical care paramedics and a HIMSS team, or it could be a volunteer first responder crew who are overwhelmed and trying to do their very best. But regardless, utilizing them when they arrive and not allowing them to leave if they can stick around, you may find the patient does better and you have more pairs of hands. Just in terms of what is really encouraged to focus on from this handover with the patient's OBS, I'd encourage everyone to think about trying to do a sterile handover. So when the patient arrives, rather than getting stuck straight into it, listen attentively to the crew information, ATMIST, etc. And then the patient may have arrived because of a logistical barrier. So normally a major trauma like this would go to a major trauma center, but maybe there's a reason that the patient either has a skill requirement, so a time requirement, skill requirement, or another resource reason, or they can't fly logistically, so they're coming to you. Acknowledging that this is a severe blunt mechanism of trauma, and that has implications for ABC score, which is yet another 3-letter acronym. We love these things in medicine, and here's another one, and I'll just mention that, and James will elaborate on that in a moment. Acknowledging the patient is in shock. There may be a couple of different important causes to consider. Hemorrhagic and obstructive are the two that we need to really differentiate using point-of-care ultrasound. And then an ABC score, so this patient may actually meet that ABC score just based on the deranged observations. So that predicts the need for blood products, the major hemorrhage protocol activation. So I'll let somebody else elaborate on that further. Thanks.
James, from your sort of pre-hospital St. John perspective, obviously you're involved with sort of air desk and making decisions on where patients go to. So how might this sort of patient end up arriving on our sort of rural doorstep?
Thanks, Dave. So many people will probably be familiar with the pre-hospital destination pathways that we've introduced for quite a number of conditions, and major trauma is one of those. So we introduced a decision tree for pre-hospital staff in 2016, and what that really did was aimed to empower paramedics at the scene to identify when a patient needed to bypass a local facility and go to somewhere else, even if that's somewhere else is a lot further away and requires air transfer. But I suppose I'll make a couple of points about that. The first is that at the top of that decision tree is a box that says to them, does this patient have an immediately life-threatening problem that you can't manage? So if they've got an obstructed airway or ineffective breathing, or if they've got need support with circulation, then it directs them to go to the closest medical facility that can help. And that may well be a rural hospital. And so, often the patients that you will get turning up to rural hospitals are in extremis and actually, more sick than the patients that we routinely get transferred into a major trauma centre, because the people that you're getting are the people that are about to die and need help. And I think the second thing is that those destination policies work really well, except in a long island with bad weather. And if we can't fly the patient and the destination is and you're coming from central Otago or the far north, you may well need to stop off and be stabilised as best we can before the patient's transferred. So certainly within the National Trauma Network, we're moving very much more towards a staging sort of process where people might well be taken to a local hospital for some initial treatment whilst we're dispatching another resource to come and retrieve the patient from you, and that's what we would refer to as staging. And effectively, the key thing with staging is it's the patient's still remains a pre-hospital patient, like they're not admitted to a hospital and they don't become an inter-hospital transfer, because that adds lots of phone calls and time. So staging is a process for initially stabilizing a patient somewhere whilst additional help's on the way and the patient is going to be moved somewhere else.
From the staging perspective, it's always a bit challenging when patients arrive staged, because they are under the pre-hospital team still, and it can give slightly muddied borders. Have you got any comments around how we best work together with our pre-hospital teams to make sure that we do the right things for the patient, but don't delay patients from disappearing and doing things that maybe aren't as important but waste time from definitive care?
Yeah, it is tricky, and I suppose the key thing is making sure that everything we do is acting in the best interests of the patient. So I'd always think about, where does this person need to be, and we've got a bolus of time that we can give to this patient and make wise use of that time. So if they're going to be in your care, for where the patient might need to be is in an operating room with a surgeon controlling the bleeding. So anything that we do that's going to delay that is bad for the patient. So if we have 45 minutes where we're together with that patient and providing care to them, we want to make that time count. And so doing things in partnership with the pre-hospital team and utilising resources that rural hospital teams are really good at doing, because it's what you do every day, is important. And it's kind of like going back to the basic EMST days of not doing things that'll delay the patient's transfer if it's not actually going to add to their care.
Thanks, James. Jono, maybe I'll ask you, in terms of if this patient comes through the door, what's your sort of assessment approach going to be to sort of rapidly figure out what's going on with this patient?
I think echoing Justin's thoughts from the initial OBS, this patient is a shock trauma patient, and there's a shock trauma patient is blood loss until proven otherwise. And if a patient's bleeding, it's unlikely we can offer definitive care, so the patient needs to be out of here. But there is another differential on there, and that's obstructive shock. So I'm pretty keen to know it's not that early, and that's where the point of care ultrasound, looking at both sides of their chest, is really useful to make sure we've got the diagnosis right. Because if this patient's tensioning, we do often need definitive care at the site of rural hospital. So we want to know that early. We want to make sure we've got the cause of shock right, and then assuming it's hemorrhagic and we don't have another thing we can fix, first job is to make sure staging's happening and onward transport is onward, because that's, you know, the time critical bit. And then you've got extra time, right, to maximize the patient. And then I'm thinking about, well, what else can I do to mitigate the blood loss during the time I've got left? And that may be compression, that may be straightening long bones, pelvic binder, and then I'm thinking about putting blood back in as well. And that depends a lot about what I've got on site, but red and yellow stuff is good if I've got it, better than crystalloid. And I think we've got another slide that will talk a little bit about the lethal triad or diamond.
Yeah, so this is the ultrasound picture that I took basically as the patient arrived that rapidly told me that this patient had. So that's a positive FAST scan of the right upper quadrant, which I guess, and EFAST really comes into its own for the unstable trauma patient rather than the stable trauma patient. And that kind of can really help to tell what's going on. So now that you've got a sort of positive FAST scan, you're thinking this is probably potentially hemorrhagic. What are your thoughts from here in terms of management? Justin, what does that change for you?
I guess acknowledging that the patient is bleeding, and we see a positive finding for intraperitoneal, retroperitoneal blood, so the patient is going to need to get out. So we need to avoid doing unnecessary procedures or enter diagnostic sort of things like a CT when actually the patient needs to get to a definitive care where a surgeon and ample blood products for a massive hemorrhage protocol can be achieved. The other thing that is important to remember is in major trauma with high energy mechanisms, you can have more than one etiology of shock. So yes, while we feel encouraged that this patient is bleeding, we would anticipate that either with blood products or temporizing bleeding with direct hemorrhage control, we would hopefully see an improvement in the patient's parameters. That's variable how long that would necessarily take. But if we're not seeing the patient improve and they're continuing to get sicker, then excluding obstructive causes is still pertinent prior to sticking them in the back of the next phase to get to definitive care.
Jono or Joel, do you want to add anything else in there per se? Joel, how would that be for you sort of up north? You're in a different context up north, but if this would potentially be all that you'd have for your patient, your positive EFAST.
Yeah, well, again, as I think Justin said, a CT is not super useful in these cases, although sometimes the surgeons like them if they're stable enough, but that person needs an operation. So it might encourage the team to come a bit quicker if they see a tummy full of blood. Sometimes there's obviously, we're maybe not as wide as the West Coast, but we're a pretty long geographic area. So, and there's a few people that have stuff all over the show, so it might just speed that up, having that fast.
Yeah, I guess. Sorry, you go, Jono.
I was just going to say that question of CT always comes across, isn't it? And it's nice to know what surgeons you'll need at the other end. And if the helicopter isn't there yet and I've got a CT right next door to my trauma area, then it's pretty tempting to bang them through it and get that information. But there's an opportunity cost for doing that. And I think that's where this bolus of time concept James talked about is really important. If we've got 15 minutes before the helicopter arrives and we've got our access, got blood going, stopped other sources of bleeding, then yes, it might be useful. But we don't want to delay this patient getting to an operating theatre.
Yeah, I think that's right. If you can get the CT and it's not going to delay time, that's really useful for planning, because I guess there's a couple of options potentially for these patients when you get to tertiary services. One is the operating theatre, but two, there's potential in terms of interventional radiology as well. we're getting more conservative probably in terms of surgically for some of these patients, like with a splenic lac, of not sort of necessarily operative management. James, from an ICU perspective, what do you see when they come to you in terms of with that?
In terms of like non-operative management.
Well, I guess, yeah, the next step, because we kind of go, right, great, theatre, but that isn't always necessarily
Yeah, so I mean, like,
what
there's
happens.
been a big shift in trauma, and we operate on a lot less people than we used to, and partially that's because we are more aggressive in CTing them, and I'm sure many of us will remember being taught about the donut of death, and you should never put a trauma patient in the CT scanner. It's kind of a bit, it's a bit more nuanced than that, I think, and certainly in a biggish hospital, we would take, transiently stable patients to the CT scanner, but we'll take the whole team with us, and we'll continue the resuscitation in the CT scanner. So it's not like just sending a house surgeon and a nurse around with the patient. And I think it is good to scan patients, and actually most surgeons will really be keen on a CT unless the patient's like not supportable. If they're not supportable, they just need to go to the operating theatre. But it's like it is a nuanced decision. And I guess one of the advantages of scanning people is that, if we know what the injury is, then it helps us to prognosticate and say, actually, this particular injury is likely to be able to be managed non-operatively, and then the patient avoids an unnecessary laparotomy, which creates in itself a lot of morbidity. And it also opens up options for like radiological management of bleeding, like embolization. So certainly in bigger hospitals, that's become sort of standard practice. So I think if you're in a situation like in Dunstan, where it's relatively easy to get a CT scan and you can do it in a safe manner, and you're not going to delay the patient, and they're stable enough to do that, it's reasonable to do that. But it's making a sensible, considered judgment based on what's right.
Annoyingly, the 5G and Gore's dropped out, I think, hasn't it?
Oh no.
Have you got it? Have you got the PowerPoint there, Jono? Did Dave send it to you? Old 5G and Gore. You're on mute, Jono. We can continue. Persevere.
I'm sure it'll come back online.
Yeah, I do have it.
Oh, good. Okay,
see
you
what I
can share.
do.
I think the next thing that was coming up was about the ABC score and the Code Crimson potentially, and Justin referenced this before. So in trauma receiving hospitals, then across the country, we've instituted a kind of Code Crimson system, and it's like a trauma call, but with the addition of summoning a surgeon and anaesthetist to the patient's bedside. Often the registrars are the people that attend the trauma calls, but for a really critically bleeding patient, then we'll actually get the consultants to the patient before summoned to the patient before they arrive in hospital. Sounds like revolutionary, doesn't it? But that works quite well, because if you put a senior surgeon in front of a patient that looks really, really sick, then it tends to expedite getting the patient to the right place. So that was really what we instituted the Code Crimson for. And it was really designed we used the ABC score, which is like a 4-point score, which Justin mentioned before. So penetrating truncal trauma, a positive fast scan, blood pressure of less than 90, or a blood pressure or a pulse of 120 or more. And if you have 2 or more of those things, then it has a pretty high sensitivity for predicting that the patient's going to need a massive transfusion. And so that's kind of why we chose that score, was to to try and identify the bleeding patient. And if you think about it, you know, patient stabbed in the chest and blood pressure of 85, you know, that's pretty worrying. Or if you have, you know, heart rate's 130 and positive fast scan, that patient's bleeding. So it's actually quite a, you know, sensible score. And the nice thing for us is that we know 3 out of the 4 things before the patient arrives in hospital, and increasingly pre-hospital teams are doing fast scans as well. So, you know, a lot of the time we might know the ultrasound finding as well. So it's quite a helpful score because it allows us to kind of set things in place before the patient arrives.
You just flick it into slideshow, Jono?
I can, but then it completely crashes my 2 screens, and I
Ah.
can't see what I'm doing. Apologies.
Okay,
So that's
I've got it.
probably as good as I can get.
Wait a minute, I could try.
The nice thing about trauma is you just have to be adaptable.
Just like us.
I think I was trying to show the slide of the lethal triad, which I guess is something we're all taught at medical school, but it's perhaps getting a little bit bigger than that now, and the term lethal diamonds method mentioned. What are we thinking about there, James, as far as what we need to do for controlling hemostasis?
Oh, sorry, are we
I'm a bit far ahead. Yeah.
oh yeah.
Here we go. Thanks for your patience, everyone.
Yeah.
Apologies, I completely got knocked off for some reason.
We blamed it on Gore.
Indeed, perfect.
Right.
Um,
Flow. Go, James. Are you? Yes.
I can talk to this, but you know, all of these 3 things are bad for you when you've got trauma. So you know, trauma patients get cold. All your coagulation factors are proteins. Proteins don't work when they're not at a, you know, reasonable temperature. When you're bleeding, you use up all of your clotting factors, and so you become coagulopathic, and you become acidotic. So, I mean, this is the kind of lethal triad of trauma, which we all know. There's a bit of interest in calcium as maybe being part of that diamond of trauma. But these are the things that's nice to try and avoid if it's possible and treat. And it's much easier to like prevent the patient getting hypothermic than to manage it once it's occurred.
So this is the CT of actually this patient who ended up, and this is the time pre-local helicopters in Queenstown and pre-CT. So we, with bad weather, flew down in a tiny squirrel down to Invercargill for this CT, showing a large liver laceration that was initially conservatively managed and then transferred up to Dunedin under the sort of liver trauma surgeons. And the only reason for going to Invercargill at that point was due to lack of weather being able to get there. So in terms of circulation, I think one of the biggest things we can do in terms of stopping the bleeding is like that's really time critical. And we are not definitive care, as Jono said. That means that we need to think about transport almost before the patient's even arrived or on arrival, when we realize that there's a patient with significant trauma that needs not to be in our vicinity. And hopefully pre-hospitally, a lot of the time that has been noticed, but sometimes it is a scoop and run. Sometimes it's junior people. And so if you get 30 minutes down the track of resuscitation and haven't called the helicopter for someone that's obviously going to need it, you're going to be waiting a lot longer to be able to get them. And you're going to be running out of blood products likely in the vicinity where you are. In terms of endpoints for treatment, I think it's really important if you're not aiming for, if you've only got 4 units of blood and you've got a patient with a blood pressure of 60, permissive hypertension, aiming for a blood pressure of 70 to 80 with normal mentation. is a really good endpoint, because otherwise you're only going to be doing is feeding the bleeding and making that bleeding worse, and you're going to run out of blood products as well. As Justin mentioned, it's really easy to go perfect. There's an intra-abdominal blood, but there's usually, if you've seen that, there's probably other injuries elsewhere as well. So it's important not to stop thinking about other causes and looking for your obstructive shock causes. And then from a coagulopathy point of view, I guess we don't want to give fluids that are going to hemodilate you. You want to get tranexamic acid in pretty early. We want to make sure we keep these patients warm, or probably more to the point, stop them from getting cold, because it's really hard to warm patients. The aim is to try and keep them covered up in a warm place and use your blood warmers, which I think we don't use blood warmers that often in rural hospitals, and it often takes about 10 minutes for somebody to figure out how to do it. So if you've got this patient coming in, get the blood warmer sorted to be warmed before you even have the patient in front of you. So we're going to sort of change tack slightly. We're going to still think about the same patient, but what happens if this patient arrests on arrival in your emergency department? Because that's a little bit of a different, something that we see very infrequently and probably pretty scary. So I think, James, we might get you to talk about that in terms of an overarching approach to maybe simplify what we can do for traumatic cardiac arrest patients.
Yeah. So I suppose the key learning point is that, traumatic cardiac arrest is different from a medical cardiac arrest, and we have, ACLS algorithms drummed into us. But if you have, an empty heart from hypovolemia, or you have a tension pneumothorax, then doing CPR doesn't help, and in fact is possibly harmful. So, chest compressions and the like really don't have a place in the setting of a traumatic cardiac arrest. And I tend to think about it, we teach the concept of HOT, H-O-T-T, which is, one way of thinking about what are some of the potentially reversible causes of cardiac arrest. In medical arrest, we talk about the H's and T's, or in traumatic cardiac arrest, we talk about the kind of a HOT approach. H standing for hypovolemia, O for oxygenation, T for tension pneumothorax, and tamponade. So I guess the key priorities, if you have someone that arrests, are the most likely reason that they've arrested is hypovolemia. So the two things that you can do in that situation are A, to stop the bleeding however you can whilst restoring volume. So you want to have just push fluids as much as possible. The second thing is opening the airway, just putting a tube or an LMA in and providing oxygen. And then the third thing that you can do, which is potentially life-saving, is decompressing the chest. And the way that we would do that is just to perform bilateral finger thoracostomies. Don't go looking for signs of a pneumothorax, just do them. Don't put a needle into the chest. We don't tend to teach that anymore because, 50% of the time it doesn't reach the pleura. So the most reliable way of decompressing the chest is just to do finger thoracostomies, and very, very simple. I'm sure most people are familiar with it, but in the same place that you'd put a chest tube, it's just like the beginning of putting a chest tube in, make a 3 or 4 centimeter incision in the chest, bluntly dissect down to the pleura, open the pleura, move to the other side and do the same. That's, I suppose, the other thing you can think about is the small chance that the patient might have a pericardial tamponade, and looking for that on your ultrasound, which is the kind of second T. But that's the kind of difference in managing traumatic cardiac arrest compared to medical cardiac arrest.
That no CPR, I think that's really quite challenging, I think, for your team, even if you've got that in your own brain. So that's probably a really important thing to pre-brief if you hear from your ambulance crew that patient is just arrested or sounds like they're peri-arrest, to maybe set the scene for the arrival of the patient in terms of priorities being your airway management, or at least bagging, finger thoracostomies, blood, and that we're not going to do CPR because it doesn't tend to work, and given a good explanation why, so that otherwise everyone else in the room's thinking, why on earth aren't we doing CPR for this arrested patient?
Yeah, I mean, I think if people end up starting to do CPR, it's not a disaster, but the problem with doing CPR and someone that's arrested in this situation is it delays you from doing other things that are potentially reversible, and it makes them more difficult. So actually, you're much better off to just focus on the things that you can do that might make a difference, and that's that HOT protocol.
Especially in rural, where we probably don't have enough people to do those things in the first place.
Just looking at the chat before we move on to that one, and do we want to talk about Hannah's question now? Because it's probably more trauma before we go into neurotrauma. Do you want to take that, James, and then we can go into a different case?
Oh, yeah. Hannah said, lots of the trauma in Hawa is put in on the back of a ute, and making pathways to different hospitals can be difficult. In my job heading the trauma network, we're really very aware of that. And I was trying to put myself in the shoes of a rural clinician in a small hospital trying to deal with a patient and the frustration of making multiple phone calls. And I think that's a major piece of work for us, but actually it's something that we're very keen on doing, is to try and streamline pathways for these patients, because I'm a trauma specialist. If you've got a sick patient like that, I want them in my hospital for me to be looking after. So anything that puts roadblocks into that is a problem. A lot of places, we've instituted a single phone call system. So certainly for Auckland, they've got a single phone call acceptance system to be able to just speak directly to a specialist and expedite that pathway. We've recently instituted the same in Wellington, and we're working with Waikato and Christchurch to try and institute the same thing there. So I guess watch this space.
I think the other nice hack there that we've talked about in the past is if you're struggling with who to talk to, calling ED at a big hospital is usually pretty useful, and asking them to arrange things.
Yeah, definitely. Yeah.
But we'll change tack now and think about another case. So this is 62-year-old male, number of drinks on board, and has fell down a flight of stairs. Called into you as GCS 8, made up of eyes 2, motor 4, voice 2, and is somewhat agitated. Pulse of 80, blood pressure 125 on 70. And SAT's 96% with a relatively normal respiratory rate and pattern. So obviously thinking now neurotrauma, and getting this call as opposed to the other one. Dave, what are you thinking about when you get this call across the RT? What are you going to brief your team differently in the department?
I guess thinking of in terms of the life threats that I'm seeing, I mean, the first thing that is jumping out, I think if we forget the alcohol, because it's very easy to say, oh, maybe there's an alcohol effect here, but I think you can 100% make errors of putting things down to alcohol when they aren't. It's a reasonably significant mechanism for a sort of slightly older gentleman. I'm going to be thinking of preparing my team for intubating this patient. He's agitated as well, so just a bit of sedative with that GCS. I'm going to be thinking needing to protect his airway. And given there's a reasonable mechanism falling down a number of stairs with probably a reasonable head injury, I'm going to think about what other injuries might this patient have that we're going to be difficult probably maybe to find, because he's not going to be very easy to assess in terms of how accurate your abdominal chest assessment is from clinical findings. So for where I work, he's going to need to go through the CT scanner. He's going to get a pan scan. And I guess the question is how you manage him in terms of getting through the CT scanner.
Yes, I guess going back to what you mentioned, he's fallen downstairs. It could be other things. We've been given relatively normal and reassuring obs, which is great, but we certainly don't want to miss other trauma, because one of the best ways to look after the brain is to look after the A, B, and C, which is okay at the moment. We certainly don't want that to deteriorate. And then there's that discussion about intubating, what's our pros and cons about intubating this guy now? What do we gain by popping a tube into this guy?
From my perspective, in terms of looking at for intubating this patient, you're going to have, this is almost certainly going to be a intubate for CT for transfer, given this GCS and this picture, and he's going to need intubating at some point. We gain control of the airway rather than taking him to the donut of death and some sedation to try and control him with a GCS that's then going to be lower. So I think my approach would probably be to be intubating this patient and then moving through the CT scanner and then managing him from there. That may depend on what the skills of your team, the team that you've got around you, as well, because it's everywhere is different. All rural hospitals are different as well. So depending on what skills you have available and what help you can call on to assist you as well.
I always like to think of intubation in the neuro case as a nice to have. It's not necessarily a life-saving intervention, but we know that things like hypoxia, hypercarbia are bad for brain. So we're doing it to optimize care rather than to immediately save a life. James, Justin, Joel, do you guys have any other sort of cognitive framework that you'd work through to decide if you're going to pop a tube in this guy?
Yeah, I mean, I think it's better to do it, if you think it's going to be required, it's better to do it in a relatively controlled setting rather than in the back of an ambulance or a helicopter. It's much safer to do it in a well-lit environment where there's people around. So I mean, I think with that picture, if I was being phoned, I would have the patient intubated before they're transferred.
I agree. It's definitely a priority for us pre-hospitally of neuroprotective strategies for patients with TBI. We need to focus on avoiding hypoxia, avoiding hypercarbia, avoiding hypotension, and avoiding hypothermia at all costs. And if you can safely oxygenate and ventilate the patient and they're hemodynamically stable and you've got a short transport time, then yeah, it might you might consider not achieving a definitive airway if you don't have a very skilled team to do that. But I agree with James. My threshold would be quite low for an ET tube or an LMA in this patient.
I agree, and obviously risk to staff and patient. He's got a GCS of 8. He's intoxicated. He's agitated. He could easily lash out at staff or also do something to harm himself. So yeah, I'd have a low threshold for wanting to secure this guy's airway, even in my setting where I don't have a scanner to worry about.
It does make the decision for where the patient's going very easy once they're intubated as well. There's no CT scanner that's normal. See whether wake up this patient is going in a helicopter out of here.
I think, yeah, the decision it would be ideal to intubate this guy, and then I guess the next decision making is what does his airway look like and what's the risk benefit. If he's 150 kgs and has all his teeth and a bit of minimal mouth opening and radiotherapy to his neck, I'd be pretty keen to have some backup. But if he's thin and Malin-Party 1 and has had a number of easy tubes for an operation, then I'd be pretty keen to get on and do it. But yeah, it is all about risk benefit. There's certainly benefits, but there may be some patients that I guess the risks outweigh that as well. If we're going to tube this guy, what are we gonna do? And I guess thinking about particularly in a neuro injured patient, how are we going to get this patient through a safe intubation?
I guess what you want is a hemodynamically stable intubation. As Justin said, you don't want to be hypertensive. So in terms of what drugs you choose, because I guess there's 4 parts to it. So you've got your staff, drugs, equipment ready, and your plan for failure. So it needs to be well planned out, and you need to sort of risk assess and optimize your patient beforehand. So as you said, the blood pressure etc. 3 at this point looks good, but I'd be choosing my go-to would be fentanyl, ketamine, and rock. Sort of 1 mic per kg of fentanyl, which hopefully blunts the blood pressure spike with intubation. 1 to 2 mg per kg of ketamine, probably 1 mg per kg, given he's already DCS of 8, and 1.2 mg per kg of rock. And that's pretty much for all of my trauma patients. And a lot of even the bigger hospitals have taken to using this for all intubations. Like propofol is a very great way of having a hypotensive patient, and even 1 drop in blood pressure in terms of outcome following neurotrauma gives a significantly worse outcome. So we want to do everything to plan for that. And your airway checklists and making sure your team are on board and doing it in a controlled manner is so important for anyone probably anyone intubating anywhere, but especially in a rural context.
In the chat, I'll pop a like a acronym that we teach critical care paramedics when which is quite nice for like weighing up the pros and cons of intubating or not. It's kind of designed for pre-hospital, but I think it would be kind of interesting for people maybe.
That'd be great. Thank you.
I guess the other thing for this patient is obviously they've got a neck injury until proven otherwise. So like using your video laryngoscope, doing inline manual stabilization is, I mean, airway is the most important thing, but we want to try and not make other injuries worse at the same time. So if you've got a McGrath to use and that you're used to using, I'd be trying everything to do it that way.
Absolutely, and I'd second the fentanyl, ketamine, rock. A simple rural doctor, and that works for nearly everything. If they're not neuro injured, I'd probably skip the fentanyl because I like making my life easy. But I think there's a reasonable argument to get it in this patient. And I'd want an agent to keep the blood pressure up. And I guess having a local protocol of what you're going to use, because regardless of what your strategy of intubating them, they may still become hypotensive, and you want something ready for that. Because one single episode of hypotension will increase the risk of a severe bad neurological outcome for this patient.
Yeah, like fentanyl, ketamine, rock uranium's our standard intubation cocktail in our ED for trauma patients.
So we successfully intubated them, and we got them through a CT scanner. I guess we've now gone forward in a few years in Queenstown, Dave, and you've got your CT scanner.
Yeah, this was a Queenstown patient.
Yeah, what have we got here, and does that influence what our next move is?
I guess the first thing that I look at when I think of a 62-year-old person's brain is I look and say there's not much black there, so there's not much space in and around that brain. And some of the other signs are a little bit more subtle, but there is sort of subarachnoid blood and interparenchymal blood there, but there's no big sort of extradural or subdural or anything that's going to have any sort of neurosurgical intervention. So we're left with managing in terms of what supportive care is and preventing secondary injury, and how can we best manage this person in this way.
And so I guess, yeah, here we go. Here's the slide on what we want to think about for a neuroprotective strategy. So maintaining normal carbia, maintaining normoxia, good blood pressure control with a higher target than we would have in uncontrolled hemorrhage. Head up 30 degrees. And that's one that's easy to miss because our patients come in on a flat bed. It's certainly a thought towards actually intubating people at 30 degrees head up can help as well. And you're not constricting anything around the neck and not missing hypoglycemia.
Sorry, that end-tidal CO2 should say 35 to 40, not 35 to 45, so lower end of normal.
Yeah, so that's a good point. And I guess up until the point that this patient gets worse, we're aiming for low normal CO2, not drastically driving it down. And that sort of becomes the next question is, what would make us concerned that this guy is coning, and what are we going to do about it? So what now we've got a patient intubated and sedated, how are we going to know that they get worse? And what are our emergency manoeuvres if they get worse?
So,
So I can, so I guess, once the patient's intubated and sedated, if they've got an acutely raised intracranial pressure, there's only two things that are likely to tell you that. First is the pupils, and the second is you might see some changes in vital signs like the patient becoming hypertensive, but that's quite a late sign. So, really monitoring the pupils once the patient's intubated is really key. And if they start to develop a significant discrepancy in their pupil size, you've got to treat that like it's an acute, like the patient is coning. And I suppose the options in that situation are to give some form of hypertonic solution. So the thing I would, in my normal practice reach for immediately would be hypertonic saline. I'm pretty sure that's standard in most rural hospitals, but I'm interested in the chat if there's people that don't have that. Lots of places will either have the really concentrated stuff, which is 23.4%. So we'd normally just give 20 mils as a push in that situation, or 100 mils or so of 3% saline. And the other option is mannitol. It's a more old-fashioned option. We tend to not use it very much anymore, mainly because it comes with associated hemodynamic effects, and it's reasonably common for patients to get a bit hypotensive, which we don't like. We tend to go for hypertonic saline in the first instance. The other thing you can do if someone does acutely blow a pupil is to hyperventilate them, turn up the respiratory rate and blow their CO2 down as an emergency manoeuvre. But the key thing is they need to get to a surgeon. Rosalie, I would definitely check the pupils for 15-minute lead would be pretty reasonable.
Just to echo that point about hypertonic saline, I think for ease of use in rural hospitals and simplicity, stocking one agent and having a cheat sheet for it of what to give and when. And if the neurosurgeons really want mannitol, they can do it when they get to neurosurgery. Let's keep our life simple.
all right, we're going to move on to the last case from there. So we've kind of talked about all of these ones that have been very clear-cut decisions with significant trauma, but probably more common is the patients that we come across that are more in the grey zone of trauma. So the last patient is a patient in Kaitaia, so 75-year-old on clopidogrel who's had a fall and tripped on some rocks and hit his head. He's been knocked out, but presents GCS 15 with a mild headache, and he's got a scalp black, but no other injuries. Joel, you work in Kaitaia, so a place without CT scan. How does sort of the assessment, management, decision making look, or how do you approach this sort of patient?
So obviously, not as clear cut as the other ones. The other ones are just all heading to a big hospital and having scans, or they might even get a scan here. And obviously, this guy, when you read that story, in most big hospitals through the country, would probably just go through the scanner just so he's not sitting in the department for so long, more than anything. But obviously, a bit of a tricky one. You've got an older fella on a blood thinner, antiplatelet, who's had a fall and he's lost consciousness. He's got a bit of a headache. So what would we do in this situation? We don't have a CT scanner, and transport to a CT scanner is not easy all the time. So I guess you'd want to know a bit more information in terms of what we would do. We'd want to make sure we've done a full neuro exam and we've got a bit more information about, say, amnesia, length of time, loss of consciousness, how long since he's had the injury. Was it 5 minutes ago? Was it 5 days ago? Because they often turn up 5 days later. The last trauma we had was 5 days later. So all of those things, I think, come into your decision-making process. But I think in this situation, one of the big things that we'd use is just discuss, as long as the patient's competent and sensible to make a decision, we'd be having a conversation with him in terms of what supports he's got at home. If he chooses not to want a CT scan, or if we decide not to, has he got someone who can keep an eye on him who could bring him back if there is a deterioration, you know, from say a subdural or something like that. It takes a bit more time. Is he, you know, does he live 2.5 hours further north of Kaitaia in the middle of nowhere where there's one ambulance that there's only staff if there's not a shindig on up there, because otherwise they will go to that, etc. So that, and does the, you know, if the patient desperately wants one, then that's all of those discussions. So it's more the art of medicine, I guess, is how I'd explain it, that the way that I'd run this case. The Canadian CT head rules can't really come into it because he's excluded because he's on a blood thinner already. But he is over 65, so and also, you know, discussions with family and patient is sort of how we would run a case like this in my setting. And obviously they would have a longer period of observation. They'd probably stay, depending on time of day, they'd either stay a good 6 hours or they'd stay the night till the morning to make sure that they're still okay and see if they need a physio assessment. If he's willing to stay, he probably wants to go back to the rocks to fish more. But yeah, so that would be my approach to that case. And obviously you've got to deal with some of his other injuries and do your full sort of, you've done your primary and you want to do your secondary and tertiary surveys to make sure you haven't missed anything else, and fixing up his scalp lack, etc. So yeah, that's how I would run that case in our setting where there's no CT. And obviously he's got neurology or something like that, then that changes things, and changes your threshold for encouragement towards a long day, because it'll be 6 hours driving there and back, so plus the long wait there in the queue to get the scan. So yeah,
if the patient decided they then wanted a CT, would you then send them by ambulance the next day, or do you do the test of time and then send them by road with relatives?
Yeah, a combination of things. I think we're getting if there's a sensible relative who can take him down, then and there's no neurology, then I definitely encourage that, because it's a more comfortable ride, but also they more timely probably. And then, to be honest, in this case, if he had normal neurology, if the family were there ready to drive him, I'd probably let him go as after a few. You know, I wouldn't even do the 10 hours obs. I'd probably just do two. Make sure you've had 3 or 4 hours, and then he can go with his family. There is hospitals on, you know, Kawakawa Hospital is about 1.5 hours south of here, so it's about halfway down. So if there's any change, they can always call in for another assessment and have an alteration in their transport mode. In our context.
And I think there's lots of similar places out there around the sort of country where that's the same elsewhere. And certainly I work for Telehealth for Western Australia and certainly use that approach very frequently. And a lot of patients maybe make their own decisions around what their risk benefit is for them to decide what they want to do and leave against what maybe might be our medical advice. But you have some shared decision-making discussions with patients and family, and hopefully they go away knowing what their options are. So I guess a few take-home points. We've kind of had the two sort of main cases, sort of hemodynamically unstable patient and then the neuro case. We've looked at some of the different clinical contexts we do with and without CTs and different transport options and maybe challenges for transport in different ends of the country. There's not necessarily always an easy answer for these things, but if you can have a shared mental model about what the patient is in front of you and advocate for your patients to rural to your tertiary centres and have some maybe workarounds to manage, like was mentioned in terms of accepting ED rather than neurosurgery who won't send the patient, but trying to send the patient to where they definitively need to be at the first time for patients that clearly have pathology versus sending them to the local hospital if they need rule-out scan for a CT head for something that's possible. But recognizing that can be really, really challenging, and you kind of need to get to know your local area and people. We aren't the definitive care for all of these really sick tertiary patients, so we need to have transport sort of prioritize an early decision making, which means trying to manage patients as rapidly as possible in our rural hospitals and only doing things that need to be done to not delay the interventions that are actually going to make a difference. And I guess the last thing is there is the risk simulation course in Ashburton. The next one is in May. I think it's the 19th to the 21st, where there's an opportunity, usually 2 to 3 doctors and 2 to 3 nurses, a total of 5 people come as a team and get to run through trauma simulations as a team. And I think at this point there's one team still available for the May course. The other courses are probably the emergency trauma management course, which is a really good course as well, but just runs through probably more simulations, but in sort of in smaller teams. Both of them are really good courses with slightly different flavors.
Thank you, Dave. Now, there is a few questions, and I see, Jono, you've been going through and answering them. We did want to potentially come back to that Code Crimson, and I might put this to you, James, and even Justin, maybe like as a communication tool, and what the understanding is of people and how that should be used, because Rosalie brought up a question around what she thought it was supposed to insinuate, and maybe it doesn't. Or
yeah,
add more.
Yeah, it is a really good question. The Code Crimson is designed as a in-hospital response to a patient where we predict that they are bleeding, and that is the primary purpose of the Code Crimson. So it's really a process within a major trauma hospital for what we do when we know there's a patient coming in who's likely to be bleeding. I think it's it's not something that is really activated pre-hospitally, but we do need to know those details for the patients to to be communicated to get that response happening. So I mean, I think if you phoned up and said, I've got a Code Crimson style patient, they would definitely understand what you're talking about, and it would might be helpful. But I don't think you need to kind of memorize the components of it. In fact, I'd probably discourage that in a way. I think it's just worthwhile being aware of these are the things that come into that response, and I guess that's my 2 cents on that.
I do think it's useful, like there's certain words that make people stop and think. You can give the obs, but if you say Code Crimson, it makes people think, oh, really significant trauma, or the patient's shocked. Like there's certain words that we speak when we spoke to the services we're sending, or the helicopter that we're wanting to get, that maybe make people stop and listen. And to me, I think that's one of those words. And maybe that might be if the ICU team are going to come, that they can bring an MTP box with them, or what things you want the service to therefore bring to you when they pick the patient up.
And as Rosalie's question, where does a rural hospital fit in? It's still not clear. I guess the point is that you might have a patient brought into you who is bleeding, who you have to manage whilst we're arranging staging to go and retrieve the patient and take them somewhere else. It's useful for you to communicate to the tertiary centre or wherever it is that you're sending the patient about that patient coming in. And so, when you're, it's nice to have a heads up and be told that. But I suppose the purpose of discussing it was really to kind of raise your awareness to the concept that patients, bleeding is the major potentially preventable cause of death. And so if a patient's bleeding, recognizing that the patient's bleeding and then doing everything you can to get the patient to a source of hemorrhage control is the key priority, and everything else is an add-on.
Thank you, team. Now, Jono, do you feel that you've answered all the others in there, that we've gone over the nuances of the neurosurgery?
I can give a 2 cents on Hannah's question, I suppose, if you like, about whether they should go to a base hospital or tertiary centre. I think it depends a little bit on the patient's presentation, but to give you an idea, if the patient's got a impaired GCS and is intubated because you think that they've got a brain injury, then that patient should definitely go directly to a tertiary trauma centre. It's a bit more complicated for the group that's GCS sort of 9 to 12. and then I guess you just have to make a bit of a clinical judgment as to whether they go to the local hospital. But often, like going and getting a CT somewhere and being transferred on is not unreasonable to do. But certainly, if they're like GCSs 8 or less and they need airway management, they should not go to a regional hospital.
Yeah, I think that idea that if you're ruling out something, you think they're okay, but you want to know it's not something, then going to the place of diagnosis is good. But if you've got a high index of suspicion that something's going to need managed, then they should go where that can be managed. And that's acknowledging that sometimes you will transfer a patient a little bit too far, because you want to have a bit of a hit rate of sending patients that you thought needed an operation and didn't, to make sure you don't end up with them in the wrong spot. And that's, I guess, back to that. The one call policy is great, but in lieu of that, phoning up your ED colleagues, speaking to an ED consultant in a big centre and saying, I want this patient in your hospital, they're usually pretty accommodating rather than talking to a neurosurgeon without a scan.
Absolutely. I think we've progressed in the communication over the years, haven't we, between rural New Zealand and tertiary centres. So on that note, team, I'd just like to say thank you very much to our panel. It's been a very interesting discussion, and I really appreciate all your time and expertise this evening. Thank you to everyone else who has come in and checked in for the session. I hope you've enjoyed it. Please fill out the evaluation form. It is really useful. And actually the free text is even more useful because it helps me guide what the next sessions are going to be. Just a heads up, our next session is on the April the 7th with Professor Tony Walls, who's a infectious diseases paediatrician. And we're going to be having a look at some infectious paediatric topics. So thank you all. And we will see you next time.